nurses, public health practitioners, pharmacists, biomedical research scientists and engineers, journalists, etc. From the inception of its nationhood in 1847, Liberia has always maintained a very special link to the United States of America and have always played a major role on the world stage. Also, Liberia was always a trusted co-war ally of the United States. Cognizant of this relationship, Liberians have always turned to the United States for rescue in times of problems, be it economic, social, or political, now medical. Today, Liberia, along with countries of the Mana River sub-region, finds itself in a situation that is occasioned by the current Ebola outbreak. This epidemic is dissipating lives, breaking up families, as well as stigmatizing and traumatizing the country and its people. It is no secret that the Liberian healthcare system, as has been discussed over and over, completely collapsed under the pressure of the Ebola outbreak, while also the leadership and local health authorities demonstrated an incapability of dealing with the outbreak. Most hospitals are still closed due to the lack of basic medical supplies. Healthcare workers lack the necessary protective gears to go on the field to perform their duties. Although there have been massive import of medical support and supplies from countries of the global community, like China and India and the United States, we have yet to see a logistic plan put in place for the proper distribution and delivery of materials to intended clinics and hospitals. There is also the issue of mistrust and confidence between citizens and government authorities, as have been discussed over and over, and a total breach of confidence. The crisis has been deepened also by the appointment of unqualified personnel, particularly non-medical personnel, as spokespeople to lead government's fight against the Ebola outbreak. And this has led to wrong decisions of government, grossly contradicting public health disease control measures. Also, the unprofessional utterances from some non-medical officials have engendered wide-scale disbelief in the general population that the Ebola virus is not real. Additional challenges include the lack of trained medical personnel in specialized areas of epidemiological infectious disease control. On the side of the diaspora efforts, coordination of logistics across the United States has been difficult due to the lack of financial resources. In Liberia, reduction of air flights into the country and the lack of clear policy on duty-free process for Ebola equipment and supplies have hampered anti-Ebola efforts from the diaspora community. These are among a few examples of the looming challenges in the fight against Ebola in Liberia and the sub-region as a whole. Notwithstanding, diaspora Liberians, and as we have met with others from the sub-region, Guineans and Sierra Leoneans, have since embarked on massive mobilizations of medical supplies and materials, as well as food, and continue to send these items to Liberia and the various countries on a revolving basis. For example, partnering with other organizations and foundations, the Diaspora Liberia Emergency Response Task Force recently airlifted about 4,000 pounds of medical supplies to Liberia on August 27, 2014, set up its own distribution mechanism that was very much independent of government's control, and effectively delivered directly to healthcare facilities that were serving impoverished communities. One of those communities were the West Point community, which was locked down. And in this service, we utilize organized community involvement. It is important to note that Guinea, Liberia, and Sierra Leone were ravaged by civil wars, and this damaged the little infrastructure that these countries had. Yet, at the onset of the prevailing crisis, there were some miscalculations also on the part of the international community. First, the international community should have had the inclination that these three Mana River Union countries of Guinea, Sierra Leone, and Liberia did not have the professional and technical capacity to control the outbreak of Ebola virus, a WHO classified risk group 4 or biosafety level 4 or category A virus. Second, the international community failed to understand the cultural and traditional ties that exist among the people living in the common geographic region that connects Guinea, Sierra Leone, and Liberia. In that geographic triangle resides common ethnic groups, example, the Kisi and Mandingo, that cannot be separated by political or colonial boundaries. Third, the response of the international community was similarly uncoordinated. After looking for a while, the French government quickly went into Guinea with scientists, doctors, and medical supplies to help out. Then the British government followed suit, helping Sierra Leone alone. Liberia was left alone for a little while, left alone, and by the mercy of Samaritan Purse and Doctors Without Borders, we take our hats off to you again. Liberia was being cared for, as if British and the French government were saying to Liberia, well, you have got America, let America come to your aid. True to this, in the last several days, the US government has begun taking significant steps towards helping Liberia fight the Ebola crisis. As the WHO have since declared the Ebola outbreak as a humanitarian crisis and called for a coordinated response. In this regard, the Diaspora Liberia Emergency Response Task Force on the Ebola crisis will kindly call for the following. One, that Britain, France, and the United States create a triangular coordination of their assistance to the region for Guinea, Sierra Leone, Liberia, and Nigeria. Two, that the international community, mainly the United States of America, with the WHO, should take immediate control of the healthcare system of Liberia and the sub-region in order to resuscitate its capacity building. Three, that the fight against Ebola be conducted through a community-based approach and community empowerment through non-governmental institutions as civic groups, churches, and community organizations have demonstrated competence and experience in service delivery during the war crisis at a time. An example will be the Catholic Church through the Catholic Relief Services, and now we can make the Diaspora Task Force as an example. and civic society groups that have already organized themselves under one umbrella in Liberia presently. Their acronym is called CASE. These will be viable partners for US government and international donors. 4, that the US government actively and practically supports the proposal of the Diaspora Liberia Emergency Response Task Force for the establishment of a National Institute of Disease Control and Prevention in Liberia to conduct disease surveillance and prevent future outbreaks of Ebola and other related diseases, and establish a West African Institute for Disease Control and Prevention so as to create a network of infectious disease professionals in Guinea, Liberia, Nigeria, and Sierra Leone, as well as the sub-region, to conduct disease surveillance and prevent future outbreak of Ebola and other related diseases. 6, that the United States government or its aid agencies kindly provide assistance to the diaspora Liberian, Guinean, and Sierra Leonean initiatives that are aimed at sending diaspora healthcare professionals, among whom are doctors, nurses, public health practitioners, etc., to their respective countries on a revolving 6-week basis. 7, that the United States government kindly increase its civilian medical expertise at about 1,000 in the region in Liberia to augment the 3,000 soldiers that will be sent. And this we are currently requesting should come from the Centers of Disease Control, the National Institute of Health, and the Food and Drug Administration. On this note, we would like to thank the government of the United States of America and the Obama administration for the concrete steps it is taking in fighting against Ebola outbreak in Liberia and the sub-region. Thank you, Mr. Chairman.
Dr. Nyan, thank you very much and for your very specific recommendations to the committee and hopefully by extension to the administration and to the rest of Congress. Just a few questions. And Dr. Kukwe, when you talked about watching Dr. Brantley walking on his own and what a sense of hope that sent to you, that sense of hope was felt here on Capitol Hill in a huge way, that Ebola isn't necessarily a death sentence, that some intervention may work. And I want my first question to all of you and to Dr. Brantley, maybe in particular, since he was on the ground dealing with Ebola patients. I asked the earlier panel, how do you incentivize doctors and healthcare personnel, other than those who might be ordered to be there as part of a military deployment, how do you incentivize people to take up that huge, not only responsibility, but to incur that risk that comes with it? I know for you, and I watched your press conference when you were with the doctors who had assisted in your recovery, and I was awed by your statement of faith in Jesus Christ, your sense of that is what motivated you to do what you did in helping those who were suffering so immensely, especially when the Ebola crisis hit. And if you might want to elaborate on that, because I think it goes unrecognized that even people in governments, even people who are a part of a military deployment, very often it is their faith that is the prime motivator for their tremendous acts of love and compassion and altruism. If you could maybe elaborate on that.
Thank you, Mr. Chairman. I think there are a lot of practical things that people want if they're going to respond to a situation like this. They want to know that they're going to be safe, that they're going to have the support they need, they'll have all the protective equipment they need, but none of that provides motivation. I think the only way to get volunteers to go serve in these situations, to go serve the people of Liberia and Guinea and Sierra Leone in the midst of this terrible Ebola outbreak, is for people to have some internal motivation. And for a lot of us, that's our religious faith. You know, Jesus instructed us, taught us, love your neighbor as yourself. And he told the parable of the Good Samaritan. And when he was asked the question, who is your neighbor? The answer is whoever's in need. That's who your neighbor is. So for a lot of people, that is and could be and should be their motivation. But even for people who don't hold a close religious faith, for medical professionals, I spoke to the Senate yesterday and said, healthcare workers take oaths, such as the Hippocratic Oath, and all of us, from the time we write our application essays for medical school, we want to save the world, we want to help people, we want to serve people. Everybody's application essay says that. But it has to be true. You have to have a sense of compassion on your fellow man and an internal urge to serve your neighbor, to serve people in need. And I think the healthcare workers in this country and other countries need to remember that that was their motivation for getting into the practice of medicine in the first place. And when they have that assurance that they'll be supported and provided with the necessary protective equipment, many people don't want to make a personal sacrifice. So if they can be compensated for their lost work, or they can have someone fill in their practice to be sure that their patients don't suffer because of their service to others, those things are all helpful, but people have to be motivated from their hearts to go serve.
Your service. Would you, others? Yes,
Okay.
Doctor.
Thank you, Chairman Smith. I think I agree with what Ken said, but there are a couple of other things that we've learned because I served as the first executive chairman of the Africa Union Africa Diaspora Healthcare Initiative, is that there are a series of things that are very critical when you're talking of professionals going into, quote unquote, what they may consider hardship posting. One is the basic thing about, in addition to faith and commitment, is logistics. They want to be sure that they are going to be safe and that there is an organizing platform. Like you were asking this morning, who is in charge? That's one of the first questions that a typical professional will ask. What is the coordinating authority or coordinating body? And then while they are in the host country, the issue of safety. And then are they going to have basic supplies to do, in order to do their work? In fact, we found out that for a lot of people, until that is, they receive very specific assurances of that, they will not like to deploy. And then, of course, the issue of compensation, not necessarily getting paid for what they are earning in the United States, but some form of compensation so that they can take care of their families. And I think also the issue of nonprofits, MSF and Samaritan Purse, the more people get to know what they are doing and the fact that they are successful in deploying people in some of these countries, the more you're going to get volunteers. And then finally, with respect to Africa, the issue of Africans in the diaspora. I mean, we see what the Indians are doing, what the Chinese are doing in China. The issue of Africans in diaspora, and there are thousands of healthcare professionals. The National Medical Association has over 25,000 medical doctors. I know they have a program on the diaspora, but that is not well funded. So you do have healthcare professionals within the diaspora who, if some kind of incentives, perhaps they'll be more inclined to deploy to Africa.
Excellent point. Yes, Doc.
Thank you, Mr. Chairman. I guess the short answer to your question is really what's the mission of being a medical professional? I think most doctors and healthcare providers that I know of, their mission is very simple. That's to save lives. And they have been in a different, very, very difficult situations in the past. In the war zones, flood, earthquake, disasters, and you name it. And every step of the way they go, they take a huge risk. And this is just another challenge. And really what motivates them is not so much of what is in it for them, but I think it's so much of what they can do for others. And that's their mission. With regards to Africa, if you allow me just 1 second, Mr. Chairman, the African Union is doing its best. You know, despite all these tremendous challenges and a lack of resources and everything else. Currently, they're assembling volunteer medical professionals from across the continent. Apparently, there are about 100 of them are being mobilized and being trained in Ethiopia at the African Union headquarters. And supposedly, they will be deployed in the next 48 hours or so. So the African Union does need a lot of help. Because ultimately, I certainly don't want to come before you, and I'm sure none of us want to come before this committee 5 years or 10 years from now. What we would like to see is hopefully in Africa taking care of Africa's business and challenges. And I think the way it could be done is, despite of what we think about the situation on the ground, the African Union and the African government should be supported in every effort they are out to accomplish. And so, such as the African CDC, is something that the President of the United States mentioned and the African Union is pursuing. And the Ethiopian government introduced this. And I think they're doing a fantastic work, but they do require a lot of supports. Thank you, sir.
Let me just ask, we are going to have to leave at 1 because there's another hearing that will have to be convened. But let me just ask a question. Dr. Brantley, you pointed out that a significant surge of medical boots on the ground must happen immediately. And I asked that question, and it was right from your testimony to our distinguished witnesses in panel 1. And I frankly, I still don't have a sense, the subcommittee members don't have a sense, what is the critical mass that's necessary? It's hard to build up and build out capacity if you don't know what's needed. You also make an excellent point. I've read a couple of articles about how people are getting in taxis and they can't find a bed anywhere. And the taxis are actually getting hot. At least that's the way the author of the article put it, you know, potentially putting people at risk who get into the taxi. And you mentioned that your 120-bed isolation unit, EDLWA, is turning away as many as 30 infectious disease individuals every day. Where do they go? And again, this idea of home health care, can that be set up? Do you think that's part of the plan? I wish I would have asked that of the earlier panel, but I didn't, but I will, because that ought to be incorporated and integrated, I would think, to a response.
Thank you. Let me answer this in an orderly way.
Okay.
The Ebola treatment units are absolutely necessary for handling this outbreak, but right now they're insufficient. That's where the home care comes in. People are staying at home, there are not enough beds, and it takes time to construct new units and put beds in them and provide adequate staff. A unit with beds but without the staff is just a place for people to die. And that's more incentive for people to stay home, where at least they're with their family. So we also have to have the staff, which goes to your question as well. The home health care strategy, I believe, has been addressed by the President in his plan when I think he committed 400,000 home care kits to be delivered, and they have to be delivered without delay. And those kits, I'm not sure what is contained in them, but it has to be not only things like oral rehydration solution and Tylenol to help treat the patient with that supportive care, and there are other types of supportive care that are not possible at home, like intravenous fluids and other more technical medical interventions. But we can do some basic things like try to keep people hydrated with oral rehydration and ease their pain or their fever with small doses of Tylenol. But the more important part of that kit is the equipment to protect the caregiver. And that's going to require education of those caregivers as well. And that's where I think employing survivors to help reach their own communities. You know, survivors are stigmatized and many times can't return to their communities safely. But if they can return to their communities with the support of the authorities, with the